I would like to welcome everybody to Turnkey Pearls for Worry-Free AFO Dispensing. I would like to welcome Dr. Jonathan Moore and Jason from Upperline Health in Kentucky, and Jason Krause from Orthotica.
My name is Jason Krause. I'm a co-founder of Orthotica Labs, located in both New York and Toronto. And we are a central fabrication company, primarily producing custom-made foot orthoses, as well as custom-made ankle foot orthoses for healthcare specialists. We are going to cover mostly what I'll say is non-clinical discussion tonight. Dr. Moore is going to present some of the pearls regarding documentation and compliance for custom-made balance braces, as well as the best strategy for overcoming things like same and similar. I could tell you, as a supplier to Dr. Moore's clinic, he is a very prolific prescriber of these types of appliances. And if anybody knows a lot about getting things done correctly and compliantly in the clinic, it would be Dr. Moore. We will have an additional event coming up in October that we'll get back to the clinical format. More news on that to come. And just a couple of last things for me. My email address is jason@orthotica.com. At the end of tonight's presentation, as we've done in the past, I'll try to grab a hold of all the questions that get raised from your presentation, Dr. Moore. So there'll be at least 15-20 minutes of Q&A. And then there's going to be some links put in the chat room as we go for scheduling some telephone one-on-ones with myself and my partner at Orthotica, should somebody want some additional detail following tonight's presentation. So without taking any more valuable time away from Dr. Moore, let me introduce Jonathan Moore, and I'll see you at the end of the presentation.
Thank you, Jason. It's good to be with you, Rich, and it's always an honor, and it's always fun to do this. I'm going to go ahead and share my screen and let everybody take a look at what we're going to be talking about. So this is, most of you who are on this call are familiar with making AFOs, the value of AFOs. I'm going to spend just a couple of minutes just reviewing, what we want to do tonight, and then I'll cover a little bit on, the concept behind using AFOs for balance, and then we're going to dig right into really kind of how we overcome some of the challenges that have come up more recently, and of course the process of billing and getting reimbursed for these. I'm going to review first of all what diagnosis codes are the most appropriate. In fact, we're going to be highlighting a really valuable tool that's going to be made available to you through Jason tonight. And that is the Orthotica compliance, the AFO compliance document or packet. It will include really kind of a turnkey approach to knowing what to document, knowing what to put in your note, and the diagnosis codes. All of those things are made available to you, but I'll review them tonight. We'll talk about just kind of the process of making sure we have the right chief complaint, the right information in our notes for the physical exam. We won't get into too much depth, but we'll just kind of highlight again what we need to be doing. And I think many of you are already doing some of these things, but I hope I can kind of fine tune what you're doing to be more effective and more compliant. We still are actually, we still have to be mindful of, meaningful use and the MIPS coding. We're going to talk about some ways in which we're going to be able to incorporate those tools, those quality measures, which are very important for reimbursement with Medicare. We're going to talk a little bit about fall risk assessments and how you do that, although I believe that that's going to be an upcoming entire session on, what is a fall risk assessment, and most specifically, is there a fall risk assessment that is specific for lower extremity providers? And also, is there a fall risk assessment tool that's reimbursable? And then, lastly, we're going to spend a good amount of time just kind of talking about same and similar and how to overcome some of those challenges with that respect. So, the first thing is that we're talking about, of course, addressing a huge issue in our healthcare marketplace, and falls are a massive issue. 1 in 4 adults age 65 and older fall at least once a year, and obviously there are a lot of things that you and I can do as providers. And among the things that we can do is, of course, educate and put in place the tools that will address risk factors. Obviously, all of you know that there are certain risk factors for falling, and many of them are highlighted in this article that was published in Gerontology, where again, many of the top researchers in this area, Bijan Najafi being among them, studied the use of an AFO with patients that are at risk of falling. And what we can certainly identify is that there's a number of lower extremity fall risks that we can, of course, address through not only physical therapy, proper footwear, but through AFOs. And this study demonstrated. And so, for some, the idea of using a brace for balance may sound counterintuitive. They may not have had experience with this. Suffice it to say that there's been very good research that's been done, including the article I just showed you. But what we want to try to do in our clinics is quickly and efficiently identify those that are at the most risk. And among the easy ways to do that is simply asking your patients if they have fallen before. That's among the top risk factors for falling, is a history of falling. But then there are some very specific lower extremity risk factors that we can tether out with, again, some simple tools and techniques. And then once we've done that and we put the tools in place, once we've used the AFO and used the shoe as a way of creating a better foundation for the patients, and this is an analogy that we use for our patients often is, what is it that keeps a tree upright during a storm? It's the roots, and what we're trying to do is enhance the stability of the root system that allows us to stand upright. And again, what is that physiologically? Well, it's our postural stability. It's our ability to again address or deal with changes in proprioception, all those things. It's all of those mechanisms that can be enhanced by using AFO. The other thing that I want to just mention before we kind of get into the compliance piece of this is I want to challenge you to, if you're doing AFOs, if you're interested in AFOs, if you want to grow your AFO business, because it can be a very lucrative business, but it can also be obviously a rewarding business because you're helping people ultimately stay mobile. That's the way I look at what I do. I don't look at it as a means necessarily of stopping falls, because I can't do that through just one thing. It's going to take multiple things to stop falls, but I look at it as I'm enhancing and trying to maintain mobility for patients that need it. But one of the things that I think a lot of clinics sorely lack, and that is engagement and incentivization from staff. I'm a true believer in getting staff involved in identifying patients that are at risk, involved in the process of documentation. I have a scribe that is very familiar with these tools, knows exactly what needs to be in the note, knows what same and similar is. I don't know if you use a scribe or have staff that reviews your notes or does those things, but adding that piece is a massive way of it's really an underutilized mechanism to be able to do more, be more compliant, and generate more revenue, which is what really you need to be focused on. One of the things that we do with our staff is we teach them what to say, what not to say, to get them interested in interventions like footwear, PT, and of course the Life and Balance program, which is our program that consists of really 3 components. That's the AFO, the Moore Balance Brace, physical therapy, and of course footwear. That's kind of our triad of treatment. But giving them the right words to say and teaching them what to not to say will allow your staff to be more effective. And this is the Life and Balance program. As you can see, this is a poster that has been created, and it's a valuable tool to have in your office. I have these in all my treatment rooms. And again, it's a way to identify, validate this program for your patients, to see it in print. We also, of course, use brochures, among other things, that are made available for customers with Orthotica. One of the things I think is interesting, just as a quick summary, as a quick thought, and that is, I want you just to think about the numbers. Think about how many seniors you see in your clinic every day. Let's just say you see 20 people a day. I would venture to say that in many cases, and it may differ where you're at, but in my case, if I see 20 patients or 30 patients, at least half are going to be seniors, that many of whom are over 65. And if you look at the number of seniors that you see annually, well, that may be a bigger number. That may be as high as 2,000 or even 5,000. But I used as a kind of a working number of seniors seen over the course of a year at maybe 2,500 seniors that you see. Now that's a low number in my clinic, but it may be close to where you're at, and I'm not sure. But when you identify those that are at risk of falling, I think that it's a safe estimate to say that 30 to 50% of those 2,500 patients are at risk of falling upon doing a fall risk assessment. So let's just say that of that 2,500, that 750 are at risk of falling. And so if you look at that number annually and you look at the numbers that are eligible, and again, most are, because most all insurances cover these, but let's just say that you take a percentage of those and say 80% are eligible. So that gives you a number of 600 patients. And you look at the average net reimbursement per pair for a balance brace, a Moore Balance Brace, it's around $1,500. And that's for the pair. That's a net after cost reimbursement for a pair. We're going to look at the codes and look at those things in a second, but I just want you to kind of take just a 30,000 feet view of your numbers. Think about them. And if you take that number of what you get reimbursed times, again, a mediocre estimate of 600 patients a year that are at risk, that are eligible, that's a large amount of revenue that you're able to produce in a year if you have the right tools, staff, and the right mindset. That's a lot of revenue that you can generate with not a lot of work. Now, if you just take that estimate and just take it in half, which I think is a very low estimate, and you take 300 patients a year that you see that are seniors, at risk of falling, eligible for AFOs, that number is still $450,000 a year net revenue. Even if you reduce that even further to 100 patients that are seniors at risk for falling, eligible for AFOs, that's still a massive number. And yet, what's interesting in that the clinics that see the most of these patients oftentimes do the least number of interventions. And I think that's kind of sad, but whatever you're doing, let's just say that if you're educating the patients, maybe providing footwear, which may be not reimbursable, I just challenge you to do something. This slide is just to demonstrate that if you do something and you do it with a cohesive plan that includes, of course, an AFO, that plan can be very valuable, not only to your patients, but to you and your clinic. And so this isn't, these aren't pie in the sky numbers, nor are they numbers to scoff at. They're real numbers because I produce these kind of numbers every year. And I think that I have impacted a lot of lives for the positive by doing that. And this is just an example of someone that we oftentimes see in the clinics and we rush in the room. We don't take the time to watch them walk. And all we did for this patient is trim a couple of toenails and did nothing more. If we're not looking at these patients and paying attention, patients like this, that obviously we can help improve their gait, improve their mobility, improve their balance through the use of an AFO and proper footwear, Again, if you don't think that you see these patients, they're walking in and oftentimes we're missing them. So the reality is that there are things that we can do for these patients. And the challenge is not finding them. The challenge is just looking and then putting in place a plan. There's clearly going to be some people who aren't going to be good candidates. There's going to clearly be cases in which you're going to intervene and maybe do AFOs and they're not going to use them. I mean, there's going to be people that you write antibiotics for infection that aren't going to go fill the antibiotics. So does that mean that we don't write for them? Of course not. There's going to be some that refuse because they don't think anything can help them. But I will tell you what's very important is that we be confident that we have a script in mind, that we not be equivocal, but we also, again, be familiar with the tools available to us to help these patients. And again, there's just a growing body of evidence to support the fact that our demeanor, our confidence, the language that we use can be very powerful in getting patients to follow a plan and protocol. Again, being confident and respectful, and again, respectfully persistent in some cases for patients that sometimes just don't want to change. I think proper, again, demeanor with the patients, smiling, physical contact, confident language can make a huge difference. Now, what I want to go into is, of course, we're going to be, when we talk to patients and we're getting them to try to think about interventions for their balance problems, we're not just selling them a brace. That's not what we're about. We're wanting to get them to buy into an effective and multidimensional program, and that's what the Life and Balance program is. And so once you put these tools in place, once we, again, put in place a lower extremity fall risk modification program, which is what Life and Balance is, we're going to be putting in place multifactorial interventions to help address risk for falling. Once we've done that, again, we want to close the deal by making sure we have the right tools. And among those is, of course, making sure that we're compliant. And that's where we're going to start tonight. With that introduction, we're going to start into eliminating the roadblocks. Let's dive into what same and similar is. Most of you know that most of you who've billed out or done an AFO in the past couple years, you may have at some point seen a denial that basically is a same and similar denial. And that denial, of course, is the result that there are, of course, tools in place now, there are rules in place that prevent us from providing a similar device if the patients have received a similar device within the past 5 years. Claims for AFOs with the date of service within 5 years, the date of a previously paid for AFO for the same anatomical side will be denied as the reasonable lifetime requirement has not been met. Again, and when we see this mark, and again, the remark code is going to be M3 or M25, that is when you know that you've been denied as the result of a same and similar denial. That means that the equipment is the same or similar to equipment already being used or having had received within 5 years. So I'm going to give you an example in a minute, but this is what you'll see if you, of course, are denied for same and similar. What you must do is that you must review the claim and appeal it, and there are lots of ways to do that. And in our clinic, before we became part of Upperline, of course, we had a 98% again appeal success when we did see same and similar, because we knew exactly what they wanted and we followed these rules that I'm going to share with you. So how do we stop the denials? Number one, you have to be able to identify ahead of time in order to prevent delays in payment. In order to avoid denials, you must identify if the patient's in that same or similar category. And the way you're going to do that is going to be use your MAC portal. And all of you have access to a portal. And once you've put in place, once you've identified this, you're going to put a process in place that we'll discuss that will ultimately identify for the payers, the fact that you're going to be getting them a device that's not the same and it's for a different purpose, and why the patients need this item. So once we do that, we're going to be more effective. And so of the devices that are inclusive when you do a custom AFO, if the patients have received anything over the counter, unfortunately, including an L4361, which is a pneumatic boot, including any other of these devices, and a night splint is also included. If the patients have received any of these within the past 5 years, you may see that same and similar denial. The problem is that lots of people, of course, may have a problem that requires a boot. I mean, every urgent care center or walk-in clinic on the planet is dispensing boots by left and right now. I mean, you can go into an urgent care center like First Choice or whatever it may be with an ingrown toenail and leave with a boot. So you just never know whether these patients have had these devices. So if a patient's received some prefab or custom device on the specific side in the last 5 years, it's more than likely that you'll receive a denial. And again, it's not provider specific. The patient could have received the same instrument from another doctor. Same rule applied. This is an example. The patient's received like a pneumatic walker in 2017 for something like a stress fracture on the left foot. The patients later on develop a PTDD or some other condition that requires, let's just say, an L1970 AFO, and that's several years later. Unfortunately, that will probably be qualified as a same or similar issue. So both the admins and the RCM team will have access to the DME Mac portal. All of you should have access to your own DME Mac portal. If you don't know what that is, please ask. Again, most all of your billers and administrators know how to get access to the DME Mac portal. It's easy to put the information in. For new patients, you're going to make a note that the patient, of course, is either in that if they've had a previous DME. For established patients, again, you're going to make sure you check it and communicate back that. So you want to know, and this is just an example of looking up a claim history and identifying that the patients in 2020 received a specific device, an L4397. So now that if you identify that they have in fact received a device, that you know they have it, you're going to make sure that you're going to send information along with your claim that will, again, report the fact that that device is no longer applicable, no longer needed, and that they need a new device for a new condition. So if the patient's condition was different, which in most cases it is, than the previous AFO dispensing, then indicate that in the chart. You must obviously start with the fact whether the patient's ambulatory or non-ambulatory. Previous wear is not considered a reasonable reason. Again, that's not a relevant issue, but you have to make sure that you identify this ahead of time. Now, there are ways in which the patient can be eligible to receive a new device within 5 years if you document certain modifiers, and we'll talk about that in a second. So your documentation needs to demonstrate the medical necessity. So it can't be that you just want to dispense a new AFO for no reason. You have to document the medical necessity necessitates, or the condition that necessitates the dispensing of a new device, and that new condition must be well documented. And you must document that the old device is either gone, it's not relevant, or would not work to improve the patient's current condition. And so that is critical. So most of you probably know that that you should have very detailed macros in your EHR. This is just an example that's in our Athena, our EHR for L1906. I'm not going to read this, but this is a very lengthy description of an L1906 device. This is the description for L1902, for L4397. This lecture is not to give you this language, but just to indicate that these templates and these macros are everywhere, and you need to make sure that you have them so that, again, you can provide adequate information in your notes. But when you have the need, let's just say that you have a patient that received a pneumatic walker in the past, you've looked them up in the MAC portal, they are clearly going to be the same or similar. This is what you need to do. Number one, you may have a patient that comes in and there is no conflict. They have nothing that they received. Now, and again, most of the time, when you identify a patient that needs MBBs, most of the time, they're not going to have had a prior DME device that's categorized in the same and similar. But clearly there's going to be the cases. So if that's the case, then you are clear to get pre-authorization and move forward. But if you do have one that has had maybe an over-the-counter device in the past, you need to make sure you document that the patient requires this new device for the following reasons. And this information that you see highlighted here, again, I don't want to read it, but it's all in the compliance information that we're going to provide to you. But it is expected that the patient will require the use of this device for an extended period. Goals of this device are to reduce ambulatory pain, improve joint function, blah, blah, blah. These are all helping the payers to identify the fact that they need this device for this new diagnosis, for this new condition. And again, this is the kind of information that's needed. So if you have a custom device and you're dispensing it, again, the patient requires a custom device for these reasons. And again, if they've had a same and similar issue or same or similar issue, then you need to document that the patient no longer requires this device. Notice that in the beginning of our note here, we have, after review of the appropriate DME portal, patient has received a prior DME device. And therefore, I've identified that this patient needs a different device for a different condition for these reasons. So that's what is recommended. And in my note, when I dispense, at the time of the dispensing, the custom-made device was suitable, not substandard. Again, all of this information we're going to give to you, this language is going to give to you in the Orthotica compliance packet. So when the patients come in to see you, you need to identify, has your condition been treated before, when, and how? Has there ever been an AFO dispensed? If it's custom, then you are going to be pretty tightly bound to the 5-year rule, unless there are certain conditions that are met, which I'll review within a minute. But for the most part, you're going to probably be denied unless you can provide adequate information that they need a new device for a specific reason. And if it's a new medical condition, let me just give you for instance, if you have dispensed, let's just say, an MBB to a patient, a pair of MBBs, and the patient later develops Charcot, that patient clearly is going to need a different device to address Charcot, osteoarthropathy. And so you're going to you may get an initial denial for that crow or for that other type of walker. But again, you'll have the tools to provide for the payers the fact that they have a new condition identified on X-ray, identified clinically, and their previous device was not appropriate to manage this device for reasons that are indicated. So again, that's the idea. Whether any of the AFOs dispense within 5 years, if yes, then you need to, again, follow protocols to do that. Now, there is a modifier that can be used for a patient to receive a new device within 5 years. And this is the modifier RA. And this is when a patient has either lost their device, or they've been stolen, or they have been damaged beyond repair. So what you need to make sure you do is document why they're damaged beyond repair, maybe even with pictures or a very good narrative explaining what happened with either them being stolen or whatever the case. And again, you can, order that device. And again, you want to get a CMN for any of these types of replacements, have them sign a CMN, and you can put same and similar as the indication for the CMN, So again, that can be of great benefit. So again, the RA modifier can be used if the patients, again, have several reasons. If you build the RA modifier, you can actually have the patient be able to receive device within the 5 years. You can also have the patient get a new device within 5 years if the condition or the diagnosis has changed, like the example I gave you in the change of anatomy, like with Charcot or with a trauma. The patients, again, can receive a new device if they've had a prior device, if the condition has changed. And as I said, if it's been irreparably damaged by flood or fire, if it's lost or irreparably damaged, for these reasons, you can use the RA modifier to, and again, get a proof of delivery signed, get an ABN signed. ABN indicating, again, you can use for reason for the ABN is same and similar. And again, to address that. And again, include documentation. When you appeal, include documentation explaining the need for a new device. Make sure the proof of delivery signed is also signed to the ABN of where, and again, I think it's when you appeal this, sending in an ABN is always a good idea. We have gotten a lot approved without a ABN. There's a lot of debate as to whether an ABN is needed, but I would recommend you get one. Medical decision-making is, again, the key proof of need for a new product. You must document your reasoning for them needing a new device. If they need a new device because they have a new trauma or new condition, use the AR modifier, document it, make sure that you include your x-ray report, all those things. Appeals are successful in most cases, in my clinical case, upwards to 95% of the time when you're using these tools. Okay, so same and similar, it's going to indicate on your EOB the reason why you got denied, and it's going to say M3 or M25. M3 is the most common. That means that the same and similar issues in place. And again, if the AFO is lost, stolen, irreparably damaged, or if the patient has a new diagnosis, you can again get a new device with the proper modifier. So again, what do I do? So number one, make sure you access your DME MAC portal, identify whether the patient again is in the same or similar, same and similar category. Noridian, again, that portal will only provide same and similar information regarding services provided in regions A and D, and my CGS only same and similar for regions B and C. What do I document? If you document that it was stolen or lost, use the AR modifier. The device was irreparably damaged, use the AR modifier. There exists a new or different diagnosis. Again, you must document that in order to, again, get a redetermination and appeal and get reimbursed for the same and similar rejection. As I showed you, these are the codes. It's a pain in the neck, but you will have success when you have these cases, when you document the proper information. If the patient's condition was different from the previous AFO, indicate that in the note. Make sure that you document that the patient is ambulatory. Previous wear is not considered a reasonable reason, and they say it's, again, the patient responsibility. So again, don't document the fact that it's kind of worn. That won't work. Again, example of needing a new device. I inspected the old L1902 and the upright is cracked, no longer functional. This part cannot be repaired. It is not a minor repair, and a new device is medically necessary, blah, blah, blah. Again, the RA modifier, you must, with this modifier, have a narrative that explains the reason for the replacement. Please do not put braces lost in fire and that be it. Again, just dictate a narrative that will be necessary. Replacement of a DME, again, a prosthetic item for lost, stolen, irreparable damage. Always talked about this. In some cases, there can be significant weight change or loss of mass. Again, those are all indications for the need for a new device. When you appeal them, include documentation explaining why the old device is not sufficient or appropriate. Make sure the proof of delivery is signed. And again, I'm going to review that with you in a minute. The ABN. A GX modifier should be applied to the claim indicating that a voluntary ABN has been issued to the beneficiary. A patient must be made aware of the potential issues in advance. And again, our success rate is over 97%. Now, what I want to do real quickly is just to highlight for you the orthotic compliance tool, which I think will answer a lot of questions. And so let's begin by just digging into this document. This is kind of the overview of the document. Number one, there has to be, again, a document of medical necessity summarizing the necessity of the brace, details reasons why a custom is needed over an OTC. We're gonna have in place for you a template or a standard written order, which is basically easy to turn around, easy to use. We're gonna have a proof of delivery, which is vital to get reimbursed. We have to give the patient the supplier standards. And then what we've also done is created some sample chart notes, which I'm going to review carefully in this session. Okay, all right. So let's go through, first of all, this is a summary of medical necessity. Now, if you look at this closely, and by the way, all of these tools that I'm showing you right now are available. And again, Jason will give you his email when we're done for you to get access to this as a customer. We'll share this information with you. This is a summary of medical necessity. I ask of you, I plead of you, don't use this as the entirety of your EHR note. There are doctors who do that and still do that. They just literally check these boxes, scan it in, and that's all they do. It will not pass an audit. These pieces are fundamental that you document, but this is a summary. So I'm just showing you that this information all is required in your note. If you want to check these off and put this in the note, that's great. It just needs to also be in your EHR note. So scanning this form in and feeling good that you've got all the stuff you need is not going to be sufficient. All right. Now, this is the standard written order, which is required by Medicare for AFO devices, including diabetic footwear, among other things. So what you have here is you have the doctor name, patient name, prognosis, the duration of use. You must document for a custom device that it's going to be greater than 12 months or 12 months or greater. If you don't indicate that, that is vital information on your written order. Again, this is the prescription for the AFO device. You must have, again, the diagnosis code, and you must also have the product codes that you are using. All of them are just here. They're checkbox. It's easy. And then you're going to check off the therapeutic objectives, which are going to, for the most part, be almost all of those. Check those off, signature, MPI, date, and now you have your prescription. Now, as you can see, everything's been done for you to make ordering the MBB, and in this particular case, other types of braces, very simple. Okay, the next document is going to be your chart note. And what we've done here is created a sample chart note that is created. And again, we don't necessarily mean that you scan this in and you do nothing more, but you're going to check off what product was dispensed. And then you're going to basically use this same language in your dispensing note that says something to the effect that a custom molded device was dispensed, fit to the patient's foot. Upon gait analysis, the device appeared to be fitting well, blah, blah, blah. Upon gait analysis, the application of the Moore Balance Brace there, AFO, there is, and again, it documents what you're seeing as far as improvement. There's good fit. So this is a sample dispensing note, which is very important for documentation. And then you have your supplier standards. It is required as a DME supplier that you dispense these 30 supplier standards to the patient upon dispensing any DME device. That is any DME device. You must dispense these supplier standards. So it's made available here. So again, this is the proof of delivery. So this is basically a document the patients are going to sign. The supplier will sign it as well, but proof of delivery indicates that the patients have received their device, that you've given them instructions for use, which are all available to you right here. So again, it's all turnkey, simple. You're documenting what brace was dispensed. You're giving them instructions, and the patients, of course, will sign it indicating that they have received it, that they received the device. Okay, so now what we've done here is we have kind of gotten a little bit into the detail of your note. So when you're creating a note, when you dispense a Moore Balance Brace, and again, this is not just a Moore Balance Brace, but any similar AFO device, you must have these characteristics or these features or this language in your note. So, and again, this is typically going to be in your note the day that you prescribe the devices. So Mrs. Jones comes in, you present the information. Mrs. Jones says, yes, I'd like to be casted. You've done a fall risk assessment, and this is going to be what your document is for that visit. You're going to make sure that there's language in the chief complaint that indicates that the patient has a problem. You do not want to be ordering AFOs and having stuff drop down in your chief complaint or your musculoskeletal section that says normal anatomy, normal gait, and then not have anything in the note about the patients feeling unsteady on their feet. So again, we've given you really all the language that you need to be compliant when you, again, prescribe in a Moore Balance Brace. You're going to have the information that you need insofar as what you need to document. Like for instance, it says, patient also notes difficulty picking up her feet when walking. I'm not steady on my feet, blah, blah, blah. Again, have this information in your chief complaint. Secondly, in your musculoskeletal section, probably the number one cause that I have seen in reviewing chart notes for doctors who've gotten denied when they've been audited is they'll have all this stuff in their note, but then under the musculoskeletal section, you know what it says? Normal gait, normal anatomy, because they just simply didn't put anything. And so what defaults in your EHR is normal, 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 and you're not going to win an audit or win anything if you have normal and normal, and you're prescribing AFOs. So what I've done is I've provided, and again, I literally took this directly from the CDC website, the gait evaluation, check all that apply. This indicates that you've watched them walk and you've identified these characteristics. One of them is slow tentative pace, loss of balance, ataxia or uncoordinated gait, short strides, in block turning, shuffling. These are all things that came from the CDC website. Then I'll kind of highlight this a little bit different, but in just a minute, but you need to perform some objective test. And one of the easiest to document and easiest to do is the timed up and go test, which is again, a CDC validated fall risk assessment tool. And the bottom line is that you're going to have them walk a short distance, and then you're going to identify whether they're able to stand up from the chair, walk that time, walk back. Again, I'll go through this in more detail in a minute. And if they can do that in under 20 seconds, which most people who are on walkers will not be able to do, that means they failed their timed up and go test. So in this form, you're going to either watch the patients walk, time them, identify whether they would pass the timed up and go test. If they fail that, which many of my patients do, then they have of course, a abnormal, or they fail the timed up and go test. Secondly, what is very important is that you document you've done some form of muscle testing. This is another thing that many doctors who've done a lot of AFOs and maybe had some challenges in getting some approved is they have nothing in their musculoskeletal section indicating they've tested muscle strength. One of the number one diagnoses for the Moore Balance Brace, or really for most all of AFOs, is muscle weakness. If you have nothing to validate that, good luck. Again, you're going to need to document that. So what we've done is we've created just a very simple plug-in numbers of just, again, the major muscle groups. And again, you can fill this out in a couple seconds, but we check the assessment. You're going to have, again, the assessment basically is the diagnosis. And here are the diagnoses that are the most commonly used for the Moore Balance Brace. A foot drop, ataxic gait, muscle weakness, unsteadiness on feet, ankle instability, difficult in walking, and then of course there are other diagnoses as well, but these are the predominant ones we use. And then you have your plan of care. And I have given you a sample plan of care based upon the Life and Balance program. And so if you use this, you will have satisfied MIPS 154 and 155 in one fell swoop. So not only you're meeting MIPS scores, you're also creating a report that by all accounts is going to fully validate the need for an AFO. The tug test, really simple. You basically have the patients walk 10 feet, sitting on a chair. They have to get up from the chair, walk 10 feet back, sit down. If they do that in less than 12 seconds, then they have passed. If they cannot do that within 12 seconds, they have failed and are, of course, at risk for falling in that respect. This is easy to do. It takes minutes to do. Very simple, easy to document. And then, of course, as I mentioned earlier, this is the sample EHR note. Again, I'm not going to read this, but it basically indicates that the therapeutic objectives of the AFO will be to blah, blah, blah. This device will do this. All of those things, and again, it's needed as a part of a life and balance fall risk management program. Again, all of this language is going to be made available to you for you to use in your EHR to create the perfect note for compliance. And then you're going to have your order form that's going to be sent off, and you'll use the compliance documents. So as I mentioned, MIPS 154, 155, 154 basically is doing a fall risk assessment, which you've done. And then you're going to also use 155 by basically developing a plan of care. And your plan of care is going to be, for the most part, the life and balance program, where you're going to put in place an AFO bilaterally. You're going to put in place a footwear, and you're going to prescribe PT, OT, and you're going to educate them regarding their risk of falling. That's MIPS 155 and 154. Now, I'm going to tease for you what we're going to be talking about probably next month, and that is a really sophisticated new tool that's now available to you to use electronically to create a fall risk plan, a fall risk assessment, a score, and that will basically spit out for you all of the tools you need compliance-wise for again, assessing risk. This is just a sample picture of it. I'm going to tease this now. We're going to talk about it more in depth next time, so I hope you can be with us next time. And here's the kicker. This tool that I'm going to share with you is reimbursable. It is the only validated by coding experts, validated fully by not only PTs, OTs, but other physicians. Even orthopedists are using these codes for the billing of a fall risk assessment. Stay tuned. If you're interested in that, which you should be, join us maybe next month. All right, so I've gone through this quickly. It's 8:19. It's 8:20. I'm going to highlight a couple of things to just note. Number one, use tools available to you, the poster, the brochure, samples. And not only will you be successful in helping patients be more balanced, be steady, but again, you're going to be creating, hopefully a better mobile patient. Use the tools available to you. There are lots of studies that highlight the benefits of the Moore Balance Brace. There are new and enhanced, by the way, number one risk factor for falling, muscle weakness. Number two, history of falling. Number three, gait deficits, balance deficits. Again, these are studies that indicate that we are seeing these patients. We can do the fall risk assessments. We can document the need for AFOs and, again, be very effective. Just so you know, if you're not familiar with the new features of the newly designed MBB as of just about a year ago, these are just a quick snapshot of some of the new features: better extrinsic posting, more stability, single Velcro strap, all leather, a true arch, and just to show you again how patients can walk with these using heel to toe. Again, watching patients improve their walking, their gait. This is what I love doing, because the patients tell me that, and these are just, and by the way, a true AFO should match the patient's arch height. And this is one of my pet peeves with a lot of the knockoffs in this market, is they have devices that literally look prefab. I am really proud to say that the Orthotica Moore Balance Brace is the best that has ever been insofar as really capturing true arch height. This is an example here.
I like to wear these. They make my feet feel more firm.
Yeah, so patients over and over again comment on how these help them.
Tell me kind of
It feels so good.
And so I could spend more time with that, but I'm going to just stop here by telling you that there are 3 codes, L1940, L2330, and L2820, all of which are the 3 codes. They're PDAC approved. Again, you're looking at approximately about $1,500 per case for a pair. And again, it's been through a lot of history. These things have been around for a while, but I will tell you that the version that exists today, I'm really proud of, and I hope that you'll find the tools that we're going to provide for you to be helpful to not only provide these tools for your patients and feel confident about it, but also to do it in a compliant way where you're not worried about being audited. I'm going to stop here. I'm going to stop share. Jason, I'm going to turn it back over to you. And I'm really grateful to be able to go through this. I hope it was helpful. And I'll let you talk about how they can get access to that work that we've put in to create that tool.
Dr. Moore mentioned multiple times our compliance package. I do make it available. Have sent it out to a lot of people since creating it almost a year ago, and I'd be happy to send it out to anyone on our program tonight. Simply reach out to me at jason@orthotica.com, just requesting the AFO compliance package, and I'll shoot you it over in PDF format that you can use to start creating templates within your practice. We've done these now 6 months in a row, and I do get requests for some in-depth conversation between some of the folks at Orthotica and people that have either attended or were referred to by people who attended. And the easy way to schedule that type of a call is on our website, which is orthotica.com. And there's a calendar icon on there, and you could simply go onto that, schedule a 15 or 30-minute call at your convenience, and we would send out an invite and connect via Teams. I do want to echo one of the things that Dr. Moore said, which is the Life in Balance fall risk assessment tool. It is being completed literally as we speak. Dr. Moore will be actually testing it out in his clinical practice, hopefully before the end of September. It's scheduled for a launch the first weekend in November. And so in our October meeting, we will be highlighting that tool. It creates a fall risk scoring, which we think is essential in patient presentation and documentation, based on the CDC and CMS guidelines. And it also will produce an entire package of compliance documentations with all the forms that Dr. Moore just presented tonight in an automated way. So once you wind up going through this fall risk assessment, determine that somebody needs a brace, this new tool will automatically pre-populate all the appropriate fields and make that available for printing and get your patient's signature and so forth. So it's truly a digital workflow end to end, and we're excited to launch that in November. One last thing about the Moore Balance Brace, and then I'll shut up. But on the website, if you go to the AFO section of the website, all of our images of our AFOs were shot in 360-degree format, so you could rotate the braces. I know I get a lot of requests for samples. It's hard to make a lot of samples of this product while we're trying to make a patient product at the same time. But I think you can get a really good feel for the look and feel and the features that Dr. Moore, simply by rotating the brace around. And that's all of our AFOs, rotating it right on the website. You can get to see from all the different angles.
Jason, do you see the question in there from Sonia?
Yeah, so the question is, how durable is this AFO, and how frequently can you replace it with insurance covering for it? So I think Dr. Moore covered the replacement question pretty thoroughly. It is expected to last 3 to 5 years, and unless it's irreparably damaged or that the patient has a new diagnosis that cannot be corrected using the previous brace, those are the replacement criteria. As far as the brace itself, one of the big changes that we made in the MBB, after maybe 10 years on the market, I think, John, was to change the fabric that used to be the outer cover to a very thin but very high quality leather covering. And that change has really, rendered this brace, I wouldn't say indestructible, because people, are pretty hard on the braces, but it certainly doesn't look like it needs to be replaced 3 months after dispensing, which our previous construction did. So this is a pretty big upgrade in terms of the durability. We've been making them for Dr. Moore's clinic since November of 2021, and I have not seen a single brace come back for a refurbish yet. So if that's any indication, we don't know how long it's going to last because it's only been 2 years, but we haven't seen any requests for recovers. So hopefully
That's a great question, and I'll echo what Jason said in that durability was a concern with the prior incarnation. We tried to use materials that handled moisture and that were light, but unfortunately they wore out faster. But going to the all other design has remarkably extended their lifespan. And Jason, I have some patients that are on their third, or even I have some that are literally on their third MBB after 5 years.
Mm-hmm.
Quite a few actually. So number one, it reminds me how old I am, and it also reminds me that patients come back and want, they want a new one. And so when their 5 years hits, I mean, I have a long slew of patients that come in and are ready to get their new set.
Yeah. John, you're not old.
You need new glasses, buddy.
Yeah. Any other questions? If not, or if something comes to you following tonight's presentation, again, feel completely comfortable in reaching out to me via email. And again, I'll track down the answer if I don't have it immediately for you. And if you would like your copy of our compliance kit, you're an email away from receiving it. And stay tuned for next month, because we've just automated from end to end the entire assessment and compliance into one very easy to use app on a tablet. And we're excited to share that with you in October. Thank you again. It's always gratifying to have people share their valuable time to learn something at night. And we look forward to continuing our series for the remainder of the year. So Rich, thanks for hosting.